Elliot, thank you for that very kind and unquestionably inflationary introduction. And just to keep this basketball matter in terms of my shady past into perspective, I constantly have my expertise inflated by friends like Elliot. And just so the record is clear, I desperately wanted to play in the National Basketball Association as a young guy. And it was a little bit of a delusional theory because I was too small, and I made up for it by being really slow. So, Elliot, thank you for the kind words and for all the good counsel that you've given us over the years, you and Jack, and you'll hear me refer to him here. First of all, I'm really appreciative of the chance to come to this summit. I think these are particularly important gatherings. And frankly, being asked to comment on issues and the status of the debate about accountable care organizations by the likes of Elliot Fisher and Dr. McClellan, my wife and family would say, I'm being given a chance to run with the right crowd. And I thank you very much for that. The audience has decades of experience and a passion for health reform. So this morning, I'd like to spend a few minutes talking about what I believe is the premier challenge for our premier health care program. And that program, of course, is Medicare. Notwithstanding the recent bit of good news from the Medicare trustees, Medicare faces unsustainably high costs because the program has never been about what drives Medicare and Medicare's real costs. And that issue is chronic disease. Seniors entering Medicare today are sicker than when their parents enrolled, and they have more cancer, more heart disease, and more diabetes. Unfortunately, too few policymakers and health providers have recognized this fact. And that covers just about everybody in my field and a pretty fair number in yours. Currently, about 70% of Medicare patients have 2 or more chronic health conditions and account for more than 90% of Medicare spending, almost $500 billion a year. Yet when chronic care even gets a rare mention with policymakers in Washington, it's usually dismissed with, and I quote, "We've got to improve care coordination," and everybody moves on. Similarly, conversations with providers hardly ever get beyond the reimbursement issue. The Medicare guarantee, in my view, is a lifeline, a godsend for millions of older and disabled people. And improving quality and controlling costs for the chronically ill deserves a more thoughtful response than the health care equivalent of whatever. Now, I'm going to start this discussion by laying out the experience of what we call our fictional heroine, Mrs. Jones. She's fictional, but I think she is very representative of senior Medicare patients today. And she illustrates the urgent need to refocus Medicare on chronic care. Let's say Mrs. Jones turns 65 and isn't feeling so hot. She hasn't been to the doctor in a while, and she very much would like to find someone who specializes in caring for seniors. Unfortunately, there aren't any geriatric practitioners in her area, and she's really got a considerable hassle just to try to find a family physician who's willing to take new Medicare patients. Eventually she does. She shows up for her welcome to Medicare visit, and her physician finds evidence of 3 chronic conditions: type 2 diabetes, chronic obstructive pulmonary disease, and heart disease. That family doctor refers Mrs. Jones to a cardiologist and a pulmonologist for further examination and tests, and he or she also recommends that Mrs. Jones see a nutritionist to get up on diet and exercise. Now, Medicare fully covers Mrs. Jones's first doctor visit, and thank you, Affordable Care Act, on that. Unfortunately, that is pretty much the last real break that Mrs. Jones gets. Her specialist visits will require a 20% copay after she reaches her Part B deductible. She'll also have to pay copays for any new prescriptions or tests. While Medicare covers nutrition therapy, she says, well, I can manage my diet on my own, and I'm not going to go to the nutritionist. Despite her efforts at self-treatment, the diabetes gets worse. Since the family doctor referred Mrs. Jones to specialists outside his group practice, the fact that Mrs. Jones skipped those specialist visits never really got back to the family doctor. Soon after, Mrs. Jones forgets to take her insulin, and she ends up at the emergency room. She gets admitted to the hospital because of the risk factors associated with her worsening diabetes. She's stabilized, told to keep up her insulin regimen, and gets sent home with a bill for the inpatient hospital deductible. That, as you know, comes to just under $1,200. At this point, Mrs. Jones can't remember the name of her family doctor. We always tease Marco Rubio when we grab the water now. At this point, Mrs. Jones can't remember the name of her family doctor or provides the wrong name, so the hospital doesn't know where to turn in describing Mrs. Jones's condition to the appropriate physician. Now, I'm looking around the audience, and my guess is a fair number of you are saying, yup, I know patients like Mrs. Jones. That's why the health care law was passed. We're going to help Mrs. Jones, and in the future, she's going to get help from ACOs, from group practices, and health plans in the Medicare Shared Savings Program, and other demonstration projects. All of those thoughts have some validity. Unfortunately, here's why the challenge facing the hypothetical Mrs. Jones is going to remain the norm rather than the exception, absent further reform. Our first hurdle is the attribution rule for the accountable care organizations in the Affordable Care Act. Under this well-meaning rule, ACOs must serve everyone who comes through the door. This rule exists for a very legitimate reason, that too many providers might want to shed risk and avoid the sickest patients. However, the unintended consequences of attribution in its present form, as it relates to chronic disease, are significant. In its present form, the attribution rule limits accountable care organizations who want to specialize in chronic care from reaching out to the sickest seniors and providing them with the integrated, quality, affordable chronic care services that we know are so important. The second issue is the current gap between where ACOs are now located and where the largest number of sick seniors are living. For example, the evidence shows that ACOs are not being set up in Alabama, where there are many seniors in very poor health, but there are going to be a fair number of ACOs in Massachusetts where the seniors have the good fortune of being some of the healthiest in the country. So we have that slide up on the board to show you, and the green map shows where diabetes is concentrated. So take a look where diabetes is concentrated in America. So you'll notice in that circle that Alabama is a deep red. The other map, which is, as you can see, mostly white with a bit of red, shows where Medicare ACOs predominate. In Medicare, there are 6. In Alabama, there's a large void. despite the very large burden of chronic illness, including diabetes. Massachusetts and Alabama have roughly the same percentage of people on Medicare. Massachusetts spends more than the national average on Medicare, while Alabama spends less. Healthy seniors in Massachusetts can access 6 Medicare ACOs, and more vulnerable older people in Alabama have none. The third important issue for us as we look to the debate about chronic care is, at present, even if you are in an ACO, you may not be lucky enough to have an individual care plan. And of course, individual care plans are the centerpiece of top quality, coordinated care. This is because the current ACO rule is ambiguous about who is entitled to an individual chronic care plan. The text of the rule talks about high-risk individuals having to have an individual care plan. But talking to practitioners, there's a lot of debate about whether our hypothetical Mrs. Jones would reach that threshold. Even if Mrs. Jones could find an ACO in her area and flip back to the fact that she had problems even getting a doctor in her area, let alone having access to an ACO, it's unlikely she would have received an individual care plan because her practitioner didn't consider her chronic conditions high risk. Fourth, ACOs are barred from creating incentives or better health rewards. These, of course, are important to encourage seniors to be as healthy as possible. We made some good headway on that in the Affordable Care Act with respect to the non-elderly population, but as perhaps we'll talk about in questions, all these issues sort of got passed over in the discussion. I mean, I can really look at counting on the fingers of one hand the number of times we even got into chronic care, and really the only thing in the act that relates specifically to the population, I'm very grateful to Senator Burr and Senator Isaacson, Republican from North Carolina and Georgia, who joined me in the Independence at Home program, but that, of course, treats people who are wholly homebound, not people who might have 2, 3, 4, even 5, chronic conditions. So we want to encourage healthy behavior, to reward healthy behavior, and in Mrs. Jones's case, her doctor saw that she had diabetes but had no way to encourage her to go for a retina scan or to see a nutritionist. And I know some people say that these kinds of incentives may be small things, but they can have a big impact on seniors on a tight income. And I've had a chance to really dig into this issue because the Cleveland Clinic and the Oregon Health Sciences Center have helped Senator Portman and I introduce the first legislation on this point, the Medicare Better Health Rewards. We do have a bipartisan approach to try to encourage these kinds of incentives. Now, there are places that we ought to be looking at for answers to this. One of the presenters at this conference is going to be Dr. Ken Coburn of Health Quality Partners in Doylestown, Pennsylvania. And he is doing some very good work in promoting chronic care coordinated services for older people. Health Quality Partners was created more than a decade ago as a demonstration project. From the beginning, Dr. Coburn and his team have sought out seniors to try to assist with these kinds of chronic conditions. The patients are treated using a thoughtful list of interventions tailored to their individual needs. The results are really extraordinary. Hospitalization down by 39%, net health care costs cut by 28%, overall mortality reduced by over 25%. Unfortunately, our government really has not exactly been tripping over itself to help Dr. Coburn. They haven't, for example, given the green light to let him expand and tap the program's full potential. The government has limited his ability to grow the program on the ground that it is a demonstration project. It seems to me the whole point of demonstration projects, especially when the need is so great and what is driving Medicare, the chronic disease, has changed so dramatically since 1965 when Medicare began, our government ought to let successful demonstrations grow as quickly as possible so they can serve more people, and yet we seem to have not been able to do that. What Dr. Coburn has been able to do, of course, doesn't happen by osmosis. It's about active engagement with patients, active care coordination involving both the provider and the patient. I'm sure you're going to hear from Dr. Coburn about the focus of the program, but it is an impressive system of protocols and standards and training and advanced analytics. And, of course, it means doing something that our government really hasn't done much of, absent our demo now on independence at home. It's all about treating people at home. Regrettably, the current system remains mired in the assumption that patients need to do what has been done from time immemorial, and that is go to the doctor's office. This ignores the fact that, of course, we have a chance to have seniors get care where they're more comfortable, and certainly care that's more accessible to them, because certainly in a lot of rural and urban areas, even access is a challenge. And Dr. Coburn has worked on those issues as well. Another system, an urban system, Montefiore in the Bronx, really further illustrates why the approach Dr. Coburn has been taking to care management makes sense no matter where you live. Montefiore doctors understand the challenges that Medicare face because they visit them in their homes at the top of old 7-story buildings that don't have elevators. Access, of course, isn't just a problem for people in rural areas. A third promising approach, and I plead guilty about wanting to advocate for exciting things going on in my state, is used by Providence Health and Services operating in Oregon and 4 other western states. They function in those areas as both a provider and an MA plan. Now, what's noteworthy about that is that they're racking up resounding successes even in a low-cost state. Even in a low-cost state, they are successfully managing the needs of chronically ill seniors. They work closely with patients and reward physicians who deliver results, and we're seeing fewer hospitalizations, and we are getting better treatment at a lower cost. And again, to be able to do that in a very low-cost state, I think is especially noteworthy. So part of the reason why I wanted to discuss this is ask the question that I think ought to be front and center for policymakers. Why shouldn't we grow programs like those 3, and the last one I mentioned in Oregon, which succeeds against all the odds, so that everybody who faces chronic disease as a senior gets the kind of care that you see Dr. Coburn offering in Montefiore and Providence in Oregon? Let's get it to Alabama and all of those other similarly situated communities. The Medicare guarantee in America should not depend on where you live. And that, in my view, is the bottom line. Now, a lot of you at this point also may be thinking, well, the Pacific Northwest and some of these communities are kind of unique. And I then asked Dr. Jack Wenberg, who we all admire so much, the amazing Jack Wenberg, to look at the latest Medicare data from across the country. And Dr. Wenberg looked for me at high-quality, high-performing systems that treat patients with the most intense needs in high and low-cost states. As usual, Dr. Wenberg did his typical outstanding work, and he found that chronically ill patients can be treated at lower costs all around the country. In fact, the new evidence shows high-performing systems spent 13 to 24% less than the state averages for patients with the same needs. Those are obviously very, very substantial savings. And you look at the Medicare challenge, 10,000 seniors retiring every day for the next 20 years, 10,000 seniors going on to Medicare. Washington Post, again, filled with discussion about this today as part of the challenge in terms of getting a budget agreement. And you see with these examples we're giving, the new data from Dr. Wenberg, there is really a lot to work with here as part of the next steps on health care and particularly Medicare. And my take on how these systems are doing it is pretty simple. First, high-performing systems successfully identify high-need patients during that first visit. They put in place a coordinated chronic care plan right at the get-go, right at the beginning, so they're, in effect, putting in place a focus on keeping that older patient out of the hospital. That is a different approach. Patients are cared for differently, folks, and in my view, that's what Medicare ought to be all about. Instead, Washington, D.C., again illustrated by the news stories you read practically every day, seems stuck in a tired, circular Medicare debate, which largely revolves around increasing premiums for the wealthy and reducing and raising the age of eligibility. That's, if you go to a meeting with senators and conferences and the like, and you talk Medicare, that is what overwhelmingly drives the discussion. Are we going to raise the age of eligibility? Are we going to raise the premiums for older people? Those are important issues. I don't want anybody to think I'm not saying those are unimportant issues. They do not, however, reform the health delivery system for the sickest seniors. And that ought to be a priority for the days ahead. So in closing, let me say that I think the country is lucky to have so many people in this room who care about Medicare and the millions of seniors who rely on it. And to just wrap up, here are several of the solutions to the challenges that I've described this morning. First, the attribution rule ought to be modified to allow practitioners to specialize in chronic care. Our objective should be to make the adverse selection issue disappear by creating specific consumer protections for seniors in plans that specialize in senior chronic care while fully retaining the current protections against discrimination for all other seniors, which is current law. That would be number one. Number two, Medicare should guarantee high-quality, coordinated care to chronically ill seniors throughout the country. Medicare reimbursement should be reconfigured to target areas with the highest incidence of chronic illness and reward practitioners in those areas who improve care and hold down costs. Third, individual care plans need to be the rule rather than the exception for older people with more than one chronic care condition. And finally, incentives ought to be available to help keep seniors as healthy as possible. In my view, those are issues that we can address. They're all lend themselves to reforms that are within our grasp. And by the way, it means building on the good work that's already been done. Nobody's talking about setting aside a lot of the very good work that's already been done to launch this revolution in integrated care. These are steps where we can build on what's been done. Now, I know I've offered a lot to chew on here. Over the coming months, I intend to work with colleagues of both political parties to turn these proposals into legislation. These ideas, in my view, will protect the sacred guarantee that is Medicare and tackle a major driving force behind our country's debt and deficit. Seniors and taxpayers deserve no less. And I thank all of you for the chance to be with you this morning. Thank you very much.
Thank you very much, Senator. I have to adjust the microphone down. Thank you very much, Senator, for your remarks. And it's certainly impressive but not surprising to hear you hit on all these key issues for accountable care organizations' goals, and particularly the goals around improving care for chronic diseases. We have time for a couple of questions. The Senator's graciously agreed to stay on with us. So if you have any, look for a microphone in the room, raise your hand, and wait for it to get to you. While we're waiting for that, let me ask you one. You talked about a number of innovative policy ideas that I think would require legislation, like your Medicare Better Health initiative for improving the incentives around rewards for better health, Medicare health reward, better health rewards legislation. How do you see the prospects for that looking this year? There was some talk earlier this year about maybe some further Medicare reform, entitlement reform. That seems to have quieted down a bit.
Mark is being logical, and heaven forbid that logic should break out on it. I mean, there is kind of two schools of thought to it. One is, and I think there's bipartisan interest in looking at ways, no matter whether you voted for the Affordable Care Act or whether you voted against the Affordable Care Act, there are senators who want to move ahead from where we are. That's my own view. I mean, I think health reform is not supposed to be about, here's my way, and if I don't get it, I'm just going to sit around and do nothing. I mean, it's not a secret to anybody in this room that I had a different approach for health reform. I offered a bill that had 6 Democratic United States senators and 6 Republican United States senators as co-sponsors, the Healthy Americans Act. So what I tried to do, given the fact that there was an interest particularly in going a different direction on the employer-based system, to try to get as many of the features that I felt strongly about into the final reform bill. And to a great extent, the exchanges really that we ended up with reflect a lot of what 6 Democratic senators and 6 Republican senators agreed on. That was really the first bipartisan plan to offer a vision of national exchanges, farmers markets where people get choices. So I continue to believe, Mark, the better way to go is to get thoughtful legislators to say whether you voted for it or against it, you're still going to try to work in a bipartisan way to improve it. I will tell you, there are certainly senators on both sides who some just want to repeal it, so they're not interested in discussing reforms. And there are some who say, well, let's just kind of stay here. It was a challenging issue. Let's just stay put. I'm hopeful that the bipartisan coalition that would like to say whether you voted for it or against it, this is where we are. Let's not just say we didn't get what we want. Let's try to figure out how to proceed from here.
Thank you. Question in the back. And please let us know who you are when you ask your question.
Softball questions are especially welcome at 8 o'clock.
Good morning, Senator. Thank you for being with us today. I'm Cynthia Litt from Cedars-Sinai in Los Angeles. In our community, Mrs. Jones would go to the primary care physician, and that primary care physician might say to her, I can take care of your prediabetes and your hypertension, and you don't need to go see a cardiologist and a pulmonologist. But she would probably demand those referrals and probably would go to those specialists, ignore the referral to the nutritionist, but go to the subspecialists. How do we change the culture in this country that more is not always better?
Terrific question. And that, of course, is part of what coordinated chronic care really does. It speaks to the culture. I mean, there are parts of the country, as you know, where a senior doesn't feel well at 10 o'clock in the morning, calls up Johnny, who's kind of got a little bit of free time between his job, and Johnny probably doesn't feel that he spends enough time with, Mom as it is. He says, Ma, I'll be right over. We'll go to the doctor. And they figure out how to get a doctor to see him, and then we start, just as you were talking about, the pattern of tests and the like. The whole point of trying to build confidence and access to these kind of good quality, coordinated chronic care plans is in that kind of, instance. Let's even take Mrs. Jones in the instance you're talking about. She'll probably make a call to someone at the plan, probably talk to a nurse. By the way, nurses and nurse practitioners can do a lot more in these accountable care organizations and in delivering care to seniors than they're being allowed to today. And if I'd given a filibuster, I probably would have gone into that too. But the person you're talking about, our friend from Cedars-Sinai, would make that call, probably talk to a nurse or a nurse practitioner who she had built a relationship with at the beginning, and you wouldn't start that spiral of visits to all those varied and sundry people. But you're absolutely right. The culture unquestionably encourages that. In my part of the world, the Pacific Northwest, where you see Providence and Kaiser and Group Health, they've made a concerted effort to change that culture and have met considerable success.
We have time for one more question right over here.
Hi, Jerry Penso with the American Medical Group Association. Thank you, Senator Wyden, for being here. What do you think the odds are for reforming SGR this year? And do you think that any of the principles that you talked about, the 4 points, might be incorporated in that reform?
I'm very hopeful. Chairman Baucus has made it clear that he feels very strongly about SGR reform, and that, of course, would be a vehicle to start looking at a number of reforms. For example, Senator Grassley and I have proposed in bipartisan legislation opening up the Medicare database, which I think is long overdue, so that you could really get access to what amounts to the treasure trove for good data and good information that obviously would speak to some of the issues we're talking about today. So, as you know, SGR kind of percolates along until the end of the year, and then everybody throws up their hands and says, oh my goodness, what are we going to do? And we sort of extend it for a short period of time, and everybody says this is terrible, but we do it. I think Chairman Baucus and Senator Hatch and the discussions we've had in the Finance Committee shows a real determination to try to address this issue. I commend them for it, anxious to work with them, and Senator Grassley and I have made it clear at every opportunity that we see SGR reform, and the question you ask about what are some of the various aspects of reform that could be built into that vehicle, we see that as the place in which to finally open up the Medicare database across the country to practitioners and families and others, so you could really get a sense of what you can do with good information. And on that point, let me just close. I said at the beginning to be with Mark and Elliot means I'm running with the right crowd. One of the reasons that I wanted to be here this morning, and as you know, there are a couple of other things going on. Senator Murkowski and I are very involved in energy legislation, very hopeful of real reforms finally in energy policy. There are a couple of things going on, as you know, relating to the NSA, and of course I can't talk about them. But I especially wanted to come this morning because I have enormous admiration for the talent and the passion that is in this room. You all have been in the precincts of health reform for years and years. Some of you, I think I know, since the days when I had a full head of hair and rugged good looks and was co-director of the Gray Panthers. So I especially wanted to come because of your expertise. Our door is open to you. We have the good fortune of having Liz Jurenka and Jocelyn Moore from our office here as well. I kid them because I tell great practitioners like yourselves, I said, call Liz and Jocelyn nights and weekends, take all their free time. But our doors are open to you. We'd be very interested in your thoughts and ideas as we try to flesh out these proposals. And again, I thank you for having me.